This meeting is being recorded.
Okay, hello everybody. Welcome back to, or welcome in the first place to one of our little mental health webinars. So a couple things to say real quick, as usual. For those of you guys returning, this is meant to be a very safe place, a casual place. We take pride in our informality. I think you might be able to tell. Well, questions, comments are all very welcome in the spirit of kindness, both to yourself and to others in the audience. But otherwise, anything really goes here. It's meant to be a safe place to come unglued a little bit, think and feel, ask questions. So that's a little backdrop in general about our little webinars. Today, guys, a couple things. One is I'm very excited to introduce to you a friend of ours, Deven Kothari, who is an ICU doctor. And so he's going to guide us through today's subject of navigating the hospital and the ICU. As usual, Deven and I will go through, some slides to level set and kind of get us oriented to the world of the ICU. But then that's the sort of setup for the fun stuff is the Q&A. And before I cut over to Deven, I am going to try to play the role of Sonia today as well. So it may be a little, bear with us. And we do have a hard stop today, right at 11 o'clock. Normally we sometimes can go over, but not today. So we'll try to make sure to stay on cue. But let me cut over to this slide that Sonia usually handles. Sonia is fine. She's okay. She's just out, not feeling well. So, and if I seem a little foggy, I'm in COVID land myself. So if I just bear with I feel very fuzzy. But anyway, so the couple ways you can comment. One is to verbally ask a question. On the lower thing on your Zoomy thing, you'll see this raise hand. And if you click that, then I'll know to call on you. Or you can type your question in the Q&A. For whatever reason, if you prefer to do it that way, then I'll read the question. And as ever, if you want to be anonymous, that's totally fine. You're welcome. We use our names here openly, and what happens here should stay here. But then again, these are going to be out on the internet too. So it's completely your call. Feel no pressure. But if you want to stay anonymous, just mention that in your Q&A, in your question. Okay, guys, thank you for your patience. Over to you, Deven. So Deven, Dr. Kothari, tell us a little bit about your background, and then we can jump in together. Welcome.
Thank you. So my name is Deven Kothari. I'm currently the Director of Surgical Critical Care at Banner MD Anderson, which is located just outside of Phoenix. I'm from Ohio. I went to school in Ohio, went to medical school in Ohio, and then trained at the Cleveland Clinic. Thereafter, I was on faculty at Ohio State University, and then about 10 years ago or so, got asked to join the team at Banner MD Anderson in Phoenix, where I've now become the Director of Surgical Critical Care. It's for those of you that don't know, MD Anderson is sort of one of the well-known cancer institutions in the world, and which is the main campus is in Houston, but they have satellite hospitals with affiliate programs around the country, and Phoenix happens to be one of them. I'm trained in anesthesia and fellowship trained in critical care, now doing almost exclusively critical care with largely a cancer population, although, we do see a fair amount of non-cancer patients as well. I came across you, BJ, listening to a podcast. You were a guest on somebody else's podcast, and so I heard, that was the first time I'd heard of you or of Mettle Health, and then it just sent me down this rabbit hole looking at this organization that really spends a lot of this time talking about dealing and helping people navigate exactly the thing that I feel like I deal with every day.
Well, which is why we couldn't be happier that you're here with us, Deven, and thank you for finding us. We're so glad to be in contact. I mean, those of you guys listening, you may or may not know that surgical ICUs and surgical ICUs at that are pretty rough places, and they're not maybe perhaps known for their touchy-feely nature in general. But that's a false divide, as Deven points out in his work and in his person. There's a lot of care and concern happening in these places, along with a lot of technical stuff going on too. So it's a heck of an environment, not found in nature. It is
Right.
quite a human accomplishment in an entirely kind of fabricated world that you navigate. And the things you see in that setting are astounding. It's sort of a distillation of some of the most intense moments of a life. And it's so beautiful to talk to you, who also has all these sort of clinical skills to go along with your say humanistic or even perhaps spiritual skills. Just your ability to see the big picture and hold these details is really awesome. And it bodes well for the future of medicine. So thank you for being here. So over to you. So just sort of this slide is, I think, to kind of ground us a little bit in the history of how medicine, how the experience of being a patient in healthcare these days, especially in ICU, can feel pretty tough. And so I think it's kind of helpful to like locate us in history. Why is the ICU, why is the hospital, why is medicine the way it is, and why are these experiences profound but sometimes a little bit off too?
I think a lot of this is based on who's really leading patients and families through this experience. And a lot of times I think they eventually learn that they're the ones that are actually the captain of the ship. Historically, I think if you look back on medicine in this country, I mean, I wasn't there, but the way I understand it is, you probably had a family doctor who may very well have delivered you on the day you were born, and may very well have signed your death certificate on the day that you died, and took care of you throughout your entire life, and could mostly handle largely the things that happened to you along the way, and would engage in you, would know you as a person, would know you as a part of a community, was really sort of invested in you and your life and your family. And that person may occasionally reach out to somebody who is more specialized with them to help with complex things, such as a cardiologist or an oncologist or a nephrologist or something like that, to help with really complex problems if they got that way. But that was still the person that was the captain of the ship. All the communication would go through them, would reach you. Not that they wouldn't talk to you as an individual patient of theirs as well, but you had somebody that could distill down the jargon for you and help you navigate very, very difficult choices. And that, the way I see medicine now, unless you're a part of a really large system, a Mayo Clinic or a Cleveland Clinic or something like that, it's very rare to find that now. And what I see is that patients and families often find themselves as the one who's the captain of the ship. They're the ones that are trying to integrate what the lung doctors are saying, what the kidney doctors are saying, what the heart doctors are saying, what the cancer doctors are saying, and try to make some very, very complex decisions, which I frankly, I don't really know how they do that. And when they are forced in that situation to do that, we ask people that are not in medicine at all. They're lawyers and engineers and teachers and school bus drivers and Starbucks baristas and whatever, to make decisions about, should we start dialysis or should we not? Should we offer long-term mechanical ventilation or not? So I think that's part of what has led us to this point where people often don't really know and don't have a guide to help them navigate the complex things that we can now do in our healthcare system.
Well, amen. And it's it's so helpful to hear that, of course, because that's not really written anywhere. These changes kind of happened over time. The Marcus Welby kind of model, the family practice doc who knows everything about you and your family, et cetera, that kind of quietly faded, and this other thing kind of came into play in over the course of our career. It's just sort of this, and it's not written anywhere. No one's going to tell you this. So it's very helpful to hear that. And it's also a little bewildering. I mean, sometimes it feels like it's on behalf of the sort of bean counting approach to medicine. Maybe it's the dollar that's pushing us towards specializations and belittling primary care. Sometimes it seems like it's this wayward interpretation of patient-centered care.
That's right.
I don't think patient-centered care is meant to say, ask your patients to know outrageous amounts of information and make decisions under duress about things they couldn't possibly understand. I mean, it's,
Yes.
it ends up feeling like a cruel setup, whereas patient-centered care is meant to be kind and to focus on the needs of the patient, not to make the patient responsible for every decision, et cetera. So,
That's
boy,
right.
just to say, you've named the mess we're in, and it's really important to name it so we understand how to respond and how to interpret it. So one of the takeaways here from this slide, I guess, is you got to be an advocate for yourself in your family. You're going to be looked to make decisions, sometimes out of respect, sometimes out of something less savory than that. But so be prepared, whether you're a family member or a patient yourself.
That's right.
Shall we move forward here, Dev?
Sure.
Okay.
So organs are this sort of helped jog my memory about why it's so puzzling, I think, when patients come to that, when they don't have that captain of the ship to help them see the overall big picture of what's going on with them. Now, with lots of chronic disease, both in our population, but also within the individual, what we have is that people's new normal is being sick, and they often don't realize that they have accepted a new baseline for when they've been chronically ill for a while. What I usually tell patients and families is, and they're often very surprised when they come to the ICU and they find themselves requiring a heroic amount of artificial support and often given a poor prognosis, is, we're all born with more organ function than we need to survive. The kidneys are a great example. You can donate a kidney to somebody else and live a perfectly normal life. And if you think about that for a moment, it's incredibly inefficient. Why would we have so much extra? Why would you have two kidneys when you only need one to survive? And my feeling is that teleologically, when you look back on history, hundreds or thousands of years ago, you needed extra heart function, lung function, liver function, kidney function, even brain function to face a threat. So if a bear was chasing you, that reserve function that you needed would kick in, and you could outrun the bear and hopefully live. And if you didn't have that reserve function there, then the bear just got you and you died, and that was it. There was no ICU, there was no ventilator, there was no dialysis, there was none of that stuff. You either had the reserve function to kick into overdrive when you needed to, or you didn't. What chronic diseases do is they don't really chip away at the normal function you need to live. In the year 2022, we don't have a lot of bears chasing us. We're not out there clubbing an elk to death to be able to eat it and survive, right? So you need surprisingly little lung function, liver function, kidney function, brain function to get into your automobile, drive it to the grocery store, purchase some food, bring it back home, heat it up in a microwave, and consume it at home. You just don't need that much lung function to do that. You can survive on surprisingly little organ function to live in the year 2022. If you had to go out, if you had smoked for so many decades and had terrible lung disease or bad COPD, and you had to go out and club an elk, you would find out very, very quickly that you don't have enough lung function to live. But you don't know that in the year 2022. So you live this quote unquote normal life, this new normal that has happened to you over a period of time, that you think is now okay. And then something happens to you. You get hit by a bus, a global pandemic breaks out, you have a heart attack, something happens to you. And that is where you need the extra heart function, lung function, liver function, kidney function, because the bear is now chasing you. We don't have bears chasing us in 2022. The bear is COVID. The bear is a motor vehicle accident. That's the bear. And it is now chasing you. And that is when suddenly you learn that you are living on the last little air sac in your lung, or you are living on the last heart cell or the last kidney cell which was okay for living a normal life in 2022, but now the stressor is chasing you and you don't have that extra reserve organ function to outrun the bear and live. And what happens a lot of times is you'll come to the ICU and somebody like me will come and say, I really don't think we can get your wife off the ventilator. She's going to need a tracheostomy and long-term ventilator support. Or, I'm sorry, your father's kidneys are not recovering. We're going to need dialysis. And families invariably will say something like this. They'll say, what are you talking about? Like just last week, mom was at church, having lunch with her friends. Like, what do you mean that she can't live without machines anymore? And the problem was mom was living on the last air sac or the last kidney cell or the last heart cell and just didn't know it. And now suddenly with the bear chasing you, that's just this huge shock to most people, which I think is surprising when you don't understand this in the context of chronic diseases, high blood pressure, cholesterol, diabetes, smoking, drug abuse, alcoholism, whatever it might be. Those things don't chip away at the function you need to live normally in 2022. Those things chip away at the reserve function that you normally don't need.
That's really, again, really helpful context, Deven. We see this sometimes, we'll call this like functional reserve, that this redundancy that we have, this extra oomph that we have. In some ways, modern life just chews up that little functional reserve, and we live closer to an edge. And then you throw in chronic illness, which more and more of us are living with, and then you're really chipping away at that functional reserve, as you say. And we're all probably living closer to an edge than we realize.
Yes,
until we realize it. So again, really helpful context. And I suppose it's also a nod in a weird backwards way to some of the successes of modern life and of modern healthcare, that we can live with just a few alveoli or a few cells in our, that we can live on with things that would have otherwise killed us years ago. There's some upshot to that too. There's something powerful about that statement too.
Yes.
So anyway, it's kind of fascinating and this is sort of modern life for you. Again, thank you for this context.
Sure.
Move us along here. Yeah, so this one, just to kind of get at some, again, level setting. A lot of folks in the audience may or may not have had spent time in the ICU. So just to understand the kind of the gear, the environment a little bit.
So common things that we do in the ICU, one, ventilators. Ventilators take over the function. Most of the artificial support that we have take over the function of some organ that you need to survive. Ventilators usually take place of your lungs. So that is to say your lungs are not working well enough to either get oxygen in, get carbon dioxide out, or both. And so we rely on a machine to help you with that process. Dialysis being the same thing for the kidney. So that is to say they take the place of kidney function. We take all your blood in your body, take it out of your body, throw it into a machine. It cleans it, because that is the job of the kidneys, is to clean your blood of toxins and drugs and things, and then we put it back in. So that's the other one. Heart support is usually done most typically with medications that allow us to either drive up your blood pressure when it is low, or drive it down if it's artificially high, or not artificial, but it's genuinely high. We do have a variety of machines to help with heart function as well. If the pump, let us say your heart's job is to pump blood to the rest of the body, to all the other organs, and if it doesn't do that well enough, there's half a dozen at least different machines that we can use to do that as well. So that's the main. So lung, kidney, and the heart.
Is there anything worth mentioning here, Deven? Sorry to interrupt you. I mean, I know there's a lot more to it than these four, but like to your point about the heart, like ECMO and LVADs, and is there anything to mention here without getting too much in the weeds, or just to say, maybe the point really is that we can commandeer your heart function for a while in an ICU with the gear? Is that?
That's right. That's right. Yes. Yeah. So we can really take over everything. So ECMO is what most people would consider the heart-lung bypass machine. So it's very similar to what we use in the operating room when you have open heart surgery, but it is a continuation of that in the ICU. That is to say, very similar to the dialysis machine, where we take all the function of pumping blood to the organs and take that. So we take all the blood out of your body, we put oxygen in, we take carbon dioxide out, and then we force it back with some flows and pressure to make sure that it gets to all the organs. But again, able to completely bypass the heart altogether with that. LVADs being something that we could implant for you to be able to go home. But yes, there are a variety of machines that are able to do that.
So maybe you want to, I'm sorry, did I just interrupt you, Dev? What are you going to say?
So I would say those are the main three. The only point I want to make, there are some organs that we do not have a machine for. So the liver is a great example of that. If your liver fails, there really are no machines. There are very few drugs that we can use to help support what the liver does. But the only answer in that standpoint, if you have, fulminant hepatic failure, or just it's completely failed, would be a liver transplant. So the brain is another one. There is no machine that will take over what your brain does. I mean, imagine what kind of world that would be. That'd be, if you, for instance, had COVID fog, maybe you could hook into that machine for a little bit. And
it's helpful right now. I'm not sure I'd vote for it just yet, but to your point, I mean, I think one of the things here, the take home here is, I mean, it's impressive as human intervention and invention is, and an ICU is really an impressive environment. You can see how, I mean, I think this statement is kind of true. We can practically speaking prop up just about any body to continue a pulse. This is where the reductive notion of life in the medical world isn't adequate, because life per se, we can kind of keep going in ICU practically indefinitely in these ways that we've been able to kind of take over for Mother Nature for some time in some borrowed way.
That's right.
Fair statement, Deven?
Yes. Now, what people don't quite realize often with that is we can with enough machines and enough drugs, we can keep the motor running.
Right.
But the ability to get you back to a quality of life that you found acceptable is a very, very different question.
Yes.
And so, yes, these things are sort of designed to temporarily support you, and things are only temporary until they're permanent. And sometimes you don't know they're permanent until the day you die, that they were permanent. But the idea is that these things are put in to temporarily keep the motor running while we fix some sort of underlying problem. The question, though, is can we fix the underlying problem or not? So a lot of focus, a lot of attention, a lot of money, a lot of resources, a lot of glory goes into doing what you can right now to save them alive in the most dramatic fashion available. But what gets lost in that is, and then what?
Right.
So then what should we do? And that is where most people, I think, haven't stopped to pause to ask the question that you guys do.
And it is so hard too, because sometimes in the heat of things, I'm thinking of one of our beloved Mettle Health community members. So there isn't, like, it'd be nice to be able to say, well, hey, if I find myself in these shoes, and Deven, if you're my doctor, use your judgment. If the machine's going to help me live another little bit and I'll bridge it and I'll be able to get off the machine, and, then I want it. If you can't bridge me to that kind of quality of life, then, and conversationally, that makes a lot of sense. But in the heat of a moment of a code or an ICU, these things are not always clear, and you don't get to exercise that judgment. And even if you do, it could be very wrong. And what people are able to live with some daylight is also a big question, so this gets really complicated really fast with the best of intentions.
That's right. So two things. That one, if you haven't discussed these things at a time, like when you decompensate in the hospital, without a plan in place, there's a certain default track that things are going to go down. Right. And that is to institute the most aggressive supportive measures that we have available to do whatever we can to keep you alive.
Right.
That's just the default that will happen. So I don't, if that's not your intention, it needs to be made very clear. One thing that I'm not sure that most people know is, if you get hospitalized for one reason, you set some limits on what we would do. say I don't want to end up on a ventilator, I don't want to end up on dialysis, and if I require those things, I would rather not, and just make sure I don't suffer, make sure I don't struggle, but allow me to naturally die.
Mhm.
And that's a really very profound thing, a place that people have finally come to. What I don't think they know is once you leave the hospital, that's usually gone.
Mhm.
So, if you've made your code status, do not resuscitate, do not intubate, but then you get discharged. If you get readmitted, the default comes back again, unless you've formally written that down somewhere. Different states have different procedures for that. In Arizona, it happens to be an orange form. You have this orange form, you fill it out, stick it on the fridge so that if the paramedics show up, they know, not to pound on your chest and break your ribs and shock you with electricity. But it is different state to state, from what I understand. But what I think people may not know is if you leave the hospital, that gets reset unless you do something a little bit more permanent. It won't automatically be in place the next time you show up, or certainly if you show up at another hospital where they have no idea that you made this decision.
That's right. This is where this fragmented system, our hospitals don't necessarily talk to each other. So you may have made your wishes perfectly clear when you were at one hospital, and then you're on a trip and you end up at another, and they will have no
That's right.
crosstalk. This is an example of where it's very difficult to have an ununified healthcare system. There's work on happening in all these things behind the scenes on policy issues, et cetera, to try to iron these out. But boy, it's enormous quagmire for all
Yes.
these reasons. So, and what you're pointing to, Deven, just for the listeners, what Deven's pointing to here, guys, is the importance of advanced care planning. And the yellow form in Arizona, is a pink form in California, is probably called something like a pulsed or a mulched form. It's called different things in different states. But we'll move on here for now because we want to get to the questions. But just note, Deven's pointing us to the importance of having an advanced directive in place and communicating your wishes to people who know you well.
Yes.
That's how you interrupt the default settings in a healthcare system. Without that in place, it has to fall to the default, practically speaking.
That's right.
Okay, so let's move us along here. It looks like it's already 10:30. Holy cow. Okay, so here's a good one for the crew here, Deven. Like, how, as an insider, what makes for a good ICU interaction? Like, how would you coach listeners in how to navigate an ICU well? Because again, this is such an unusual environment. An ICU is not to be confused with the rest of the world. It has its own rules and functions in its own way. So how can you coach us to navigate it well as a patient or a family member?
So once you're there, I mean, there's lots of things you can do beforehand, which sort of touched on a little bit, and your book and your program does a great job of setting up. But once you're in the ICU, you will be likely barraged by multiple members of multiple teams. So it's not just an ICU doctor, or a cardiologist, or a hepatologist or something. Like, usually you are so complex in your illness that you require the specialty of multiple teams, each of which have multiple people in them. So if the ICU doctor asks for help with kidney failure, so we'll ask a nephrologist for help, but that nephrologist will probably have multiple members on their team as well, maybe nurse practitioners, maybe residents and fellows, depending on where you're at, maybe other partners that are covering for the weekend or a holiday, or a different person that's on call at night. And that's just one organ system. You could imagine if your kidneys have failed and your lungs have failed and your liver's failed, which happens quite frequently, that there are just multiple people coming in and out of your room, or constantly writing something in your chart or whatnot that you may not know. Typically, depending on what kind of an ICU you're in, there will be one ICU doctor who's navigating what each one of those team members is doing. And so that's a great person to talk to about the overall general picture of things. How are things going? What are multiple team members saying? But if you're there in the ICU, you want to make sure you get the best possible information from the right person. So you could ask an ICU doctor about what is going on with your cancer, and we can generally speak intelligently about it. We all went to medical school. We all did sort of fairly general training before we got specialized. So we can speak generally intelligent about them. But as far as very, very fine details, most importantly about prognosis, it's really best to get that from the absolute expert on your team. So whether your question is about heart failure or cancer or kidney failure or whatnot, it's important that you recognize who each person is and what their expertise is, and more importantly, perhaps what their limitations are. So if you're in the ICU with sepsis, it's really best to get your information from the infectious disease doctor. The kidney doctor can talk about sepsis, but as far as the treatment and the prognosis and what the plan's going to be, and what if this happens again, or how are we going to change antibiotics, or what's going on with my pneumonia, it's really best to leave that up to the either the ICU doctor or the infectious disease specialist. And I think the reason why I say that is sometimes you get a little bit of conflicting and confusing information when you ask somebody who it's not necessarily their specialty about something, and they might say something that you take one way, and then it will feel like when somebody else comes in the room that they say something very different, and then that adds to a lot of stress, I think, and sometimes it leads to distrust with the healthcare team, because well, this person just came in here half an hour ago and told me this, and now you're telling me that, so what am I supposed to do? Who am I supposed to believe? Do you guys even know what you're doing here? Don't you guys talk to each other? That's the kind of stuff that can happen. So I think one of the things I would say is make sure you understand exactly who you're talking to, and ask your questions to the best possible person on the team. And it's nothing wrong to say when you talk to your ICU doctor, say, I have a question about surgery. What happened with my surgical drain that had, and we may answer, and then just say, like, should I ask the surgeon about this? Or, like, maybe, just sort of ask if you're asking a specific question that anybody could answer, or is it something that's really better directed to a surgeon or an oncologist or a cardiologist or whoever. So I would say that's probably one of the big things to take away from that.
And Deven, do you think, knowing that almost by definition, if you're in an ICU, you're pretty dang sick. And if you're a family member of someone in ICU, you're probably pretty overwhelmed and scared.
That's right.
So given all that stress, if you just kind of can't keep things straight, if there's a single point of contact, is that typically the bedside nurse? If you're just spinning, you don't know how to land.
Yes, the nurse is a great person to have. That nurse is pretty much going to be in your room for 12 straight hours. You'll probably, depending on the visitation policy of the institution you're at, you may very well be in there for 12 straight hours with him or her as well. And so, they'll be a great person to ask. Just again, much like dealing with asking an ICU doctor about your cancer, just recognize that there might be limitations in the way they explain things or understand things, that sometimes, when the surgeon comes by and says, no, we're not going to the operating room today, and I have these 6 reasons why, the nurse thought the plan was we're going to the operating room today to do something, but something has now changed that your nurse may or may not know. So again, I think the nurse is a great person to ask about that, but may not necessarily be the expert in whatever it is your question is.
So it's also, I think it's probably, as you set up your questions, it's always okay to ask, because you may not even know who these people are coming in and out of your room. Like it can be so chaotic. They all look alike. They're all in gowns. Right. So it's always okay to pause and say, hey, can I ask, what team are you from? Or,
yes,
just to kind of, sometimes that can kind of basic politeness can get lost in an ICU. There's just so much going on. So it's always okay to put up a hand and say, hey, I don't recognize you. Can you remind me of which team you're with, or whatever else? Yes. Remember, it is your body after all. And it can get chaotic. And I guess another thing to mention is these places are like hospitals in general, but even more consolidated in ICUs. There's a triage mentality at all times where you as the staff are being asked to weigh between various degrees of emergency happening in your unit. And so it makes it very hard to schedule anything, to say, oh, well, the doctor will be here at 10. Well, maybe if nothing happens between now and 10. So just to note, that's not people being rude, or it's the ever dynamic nature of an ICU, where everything is being constantly weighed in terms of severity. And so sometimes your questions aren't being ignored. They're just not landing as emergent enough.
That's
So
right.
it's hard to say be patient to you as a patient in an ICU,
That's right.
but patience will serve you because you're going to need it.
One of the things that I say is we've got a model at our institution and most of the places that I've been at where the ICU doctor is there on campus the entire time, the entire day. Now, they're not necessarily standing in front of your room or at your bedside, but they are there somewhere.
Mhm.
And, a little tongue in cheek here, but, what I say is if you don't see me a lot, things are going like I'm not the kind of guy that you want standing at your bedside. Things are not going well. If I cannot even walk away from your bedside for 5 minutes, things are not going well for you.
Mhm.
So, if you don't see me for a couple hours or maybe even a whole day goes by and you didn't necessarily see me, things are going kind of good for you in the ICU.
Right on. I'm glad that you're not in scrubs right now. We are actually glad to see you, Devin. So, but just to say to one more, and then we got moving on here. Actually, I should probably get going right this second, but well, I forgot my point anyway. So,
well, let me just say this real quick. So you had the thing that what to ask. A lot of times, it's important to read between the lines of it. Talking about end of life, talking about things not going well. It's very uncomfortable for us. Most doctors, it's not part of our culture as Americans. So, yes, we are doctors, but we are also human beings and we are also Americans and we are also all those other things, so we are subject to the limitations of all those things of being a human being, of being an American, not wanting to talk about things. We come from a society where, no matter how bad things are going, Rocky is going to beat the Russian at the end of the movie. You just know that going into the movie. There's no way this movie's going to end without Rocky beating the Russian, right? So we are not a society that talks about things not going well. So a lot of times your doctors are loath to really be frank about things like that. And I think that's part of why we as ICU doctors come off, as you said at the very beginning, is maybe sometimes brash, maybe sometimes not very kind, but we don't have a lot of time. Things are moving very, very quickly. They're going bad very quickly. And I think you are going to die. And I will say that, like, I think you will die. I don't think you will survive this. I don't think you're going to go home again. And often we are the first people to say that to you or your family member, because what they've been saying this whole time is something like this. An oncologist has been saying, hospice would be reasonable. Now, hospice would be reasonable. What your oncologist is saying is you should go to hospice. We shouldn't subject you to any more of this. But they are not saying we should stop. They are not saying we have nothing more to offer you. What they are saying is, that's what they want to say, but the way it's coming out is, hospice would be reasonable. There's an old joke that we have in the ICU where, there's a patient who had a long bout of cancer, multiple lines of chemotherapy, multiple lines of radiation and surgery, and finally died. And, so at the funeral, the oncologist shows up to administer the next line of chemotherapy because he died in the middle of the cycle, So the oncologist walks up to the casket and lifts open the lid, and there's no body there. And there's a sign that says "Gone for dialysis."
Oh, man.
So, if an oncologist says you are going to die, you will die, that's really pretty profound, because they never say that. They will say something very vague like that. So, like the question that's on the screen in front of us, what to ask. A lot of times what I would suggest people ask is, what would you do if you were me? Like, what would you choose? Like, we're not really, medicine has shifted culturally to a spot where we don't really tell people what to do. We present this menu of options like it's a restaurant, and say, we could offer you dialysis, we could offer you chemotherapy, we could offer you surgery, we could offer you this whole mess of things that you honestly don't really know anything about, and you're just supposed to pick and choose. And that can be really overwhelming for people that have no medical training at all. So one question that I would encourage people to ask when they're just not sure is to say to their doctor, well, what would you do? Like, what would you choose? And then you might get your oncologist to say something like, I would go to hospice, in which case you should go to hospice. So,
and I would say even be more leading if you might even say, doctor, is hospice appropriate for me? Honestly,
that's right. Yeah.
It's to the point where and again, I'm sorry for this news, and it's come up at Mettle all the time as we it's kind of back on us as the patients and caregivers to somehow interpret these things, to translate what you're pointing out, Deven, what doctors say and what they mean. So get bold in your questions.
Yes.
And no matter what the cues you're getting from people, we do respect that this is your life. And there's just so much momentum back to this sort of the cruel riddle of, the guy in the casket getting dialysis. There is just such a momentum to this work, and there's so much that can be done, and there's so many gizmos. But just because we can do something doesn't mean we should do something. And that is a really important judgment call that sometimes, say too often, gets blown past. So it's complicated. We do not mean to blame the patients for this. Doctors, we should get better at communicating around these things. And there are efforts afoot to do so, but there's a ways to go.
That's right.
Dev, you know what, buddy? Let me just pull us out here because I want to look at the Q&A because that's where and if there's a gap, then we can go back to the slides.
Okay.
But I want to make sure. Is that okay with you?
Yes, that'd be great.
And I'll just say on this one, like you were saying earlier, like we can replace organs. We can't replace spirit or soul or personality. There's all these things that medicine's gear we can't do. So the emotional stuff, the psychological stuff, the spiritual stuff, we don't have great answers for that. And when medicine doesn't have great answers, they sort of pretend it doesn't exist. So here again, bring the humanism as you as a human being. Sorry, well, you're going to say something there?
Yeah, and the other thing, again, noting that doctors are human beings too, and many times they've been fighting this battle with you for a long time. You've been fighting cancer for months or years, or you've been slowly developing heart failure over a long period of time, or whatever it might be. That doctor may have actually gotten to know you very, very well and is emotionally invested in you and your success as well. Often those emotional bonds, I think, can make you less objective. You also as a doctor want your patient to do so, even though they're not doing well. It is emotional for you, the doctor, to come to terms with that too. I think doctors grieve a lot with patients, and a lot of what I do is I end up treating doctors more than I treating patients, because the doctor, your oncologist, your transplant team, your cardiologist, they need time to come to terms with you not doing well also. So one thing that we notice a lot in the ICU, now the ICU team, we've never known you. I met you as you were dying. That's when I started to meet you. I didn't know you. I mean, without being rude, I never knew you as a human being. I never talked to you. I never had a meal with you. I never saw you in a clinic. So all I know is the facts that are in front of me. Now, you want your doctor to be emotionally invested in your care. I mean, we all want that. But just recognize that your doctor may also be grieving. Your doctor may also be making emotional decisions as well, despite the objective evidence to the otherwise. And so, oncologist A is your main oncologist, but on the weekend, oncologist B is rounding. So oncologist A gets the weekend off. It is useful to ask oncologist B, hey, like oncologist B is not as emotionally invested in you as oncologist A is, because they're just rounding for the weekend. Transplant surgeon B maybe is the one rounding on the weekend or on the holiday or whatever. Cardiologist, like we all cover for each other, and getting information from that person who also wants you to do well, but is frankly, just being honest, not emotionally tied into you the way you and your families are. Like your families are also making emotional decisions at this highly emotional time. So keep that in mind, that you look to your doctor as this, wealth of objective knowledge and scientific credibility and whatnot, but they are human beings too. They are often very, very emotionally invested in your success. And sometimes that may skew their prognosis. It may skew their judgment a little bit. So,
amen. I mean, I think it's so important, and I hope we do it enough at Mettle, of teasing out the difference between the healthcare system and the people laboring within it. It has become as hard or harder for doctors as it has for patients or any clinicians. The work, I don't know if you saw this recent data that around, if there's an average primary care patient panel, if the average primary care doc with the average size panel were to take full care of all of his or her patients in a day, they would have to and do all the things they're supposed to do. That would be a 27-hour workday.
Oh my God.
I mean, so this system, there's more than we can get at here, but just to say, to your point, Deven, there's so much to critique in the healthcare system that is importantly different from critiquing the people working within that system who are being asked to do kind of impossible things.
That's
It's
right.
complicated. So, okay, let's see. It looks like there are a few, let's see here. In the chat, let me just read these, guys, and forgive me. We miss Sonia in multiple ways, including right now. So from Aki, not a question, but it reminds me of my father. He had lung cancer, lots of decisions to make. It's important for a patient to have a good doctor at the end of time. Excuse me for leaving early. I'll check the video later on. Yeah. So any reflection to that comment from Aki, Dev?
No, it's just so true that really that person that you need there, is not necessarily the most knowledgeable about every intricacy about your disease or your treatment, or but just somebody who could listen and go step back and see you as a person. I think it's something that you just don't see all that much, especially in the hospital, in the ICU, just because things are just coming at us so fast. So it's a great point.
Yeah. It also kind of reminds me too of the teamwork inherent. I know we're kind of toggling between the point of view of patient, point of view of clinician, and they're all in the mix here. They're all relevant. Again, this is a relationship, but it also kind of reminds me, and I think something you hinted at earlier too, Deven, which is, again, back to clinicians are people. And as people, we have some strengths and some things we're better at and some things we're less good at, or, and so the great technician may not be the guy who you want to talk to about your existential concerns.
That's right.
And that's okay. This is why healthcare at its best is a team sport. Not any one provider, not any one discipline is going to have all the answers, has all the locks on, and has all the kind of attitude or spirit to attend every moment of this journey. It's complicated. Yes. So use the team, lean on the team. It doesn't always have to be the doctor. In fact, it's plenty of times it's the nurse, it's the chaplain, it's everyone but the doctor who's really there in important ways. Okay, so here's a comment from one of our faves. Hi, Deb, longtime Mettle community member. Okay, I'm just going to read this. As a healthcare power of attorney for a woman with DRESS syndrome, what advice can you give me for making sure the hospital understands the severity of her allergies? There have been numerous times of when the hospital doesn't know what DRESS is or won't look at the allergy list of my friend and she nearly dies.
Yes, we've had this quite a few times, or something very similar. It's not necessarily that syndrome, but I would say the best possible thing to do, and I hope you or your friend live in a place that has a large tertiary care referral center, and I would say make that the place you go. I mean, unless you have to call an ambulance that is required to take you to the closest hospital, I would say go to the place that knows you. So, a lot of times it will take us a long time to figure something out about a patient. And then invariably, they'll just go to whatever hospital's closest or wherever they might happen to be, or something like that the next time something happens. And that team has to to a certain extent has to reinvent the wheel. And with these really complex patients with these very complex histories, particularly with medication allergies, I think it's so difficult. It's so difficult to really tease things out. Even if you're able to get the medical records from another place, it's a lot of medical records that you have to go through to make the best possible decisions. And so I would say that, hopefully you're at a place or live in an area where you can go to the largest place that knows you the best, and try to get the same team over and over again. I mean, that's difficult to do in the inpatient setting, but it is impossible to do if you go to a different hospital, you go to a different healthcare system altogether. So that would be my number one advice, is go to the place that knows you well. Even if you don't get the doctor that you had last time, you could at least say, hey, can you ask Dr. So-and-so about this? Because we had, they dealt with this last time and they figured all these things out. And, we may figure out things that honestly don't even end up in the medical record. somewhere, so it might be even difficult for somebody else to find. So I think that would be my number one piece of advice: is go to the place that knows you the best. Where if you had a good experience somewhere, keep going there. And I would say go to the most comprehensive place you can, because if you develop a more complex problem, although the community hospital, the small community hospital in the suburbs might know you really well, they might not be able to care for your acute heart attack or so whatever it is that you have right now. So get yourself established at the most comprehensive place that you can.
So, okay, and barring that, knowing that sometimes we just end up in various ERs or urgent cares or new providers, is there, and Deb's question can be a proxy for other questions of when you're feeling like that the team is not hearing an important piece of information. Is there some counsel of how do you interrupt respectfully to say, hey, this is dangerous, I need you to understand this, or what kind of language can we use that will really arrest that busy clinician to pay attention? Do we call an ethics consult? Do you call an ombuds person? If how do you?
Yeah, I would say those are the options that are available at every place is to bring ethics involved, and the ombudsman is a great tool as well. Sometimes it's just, like you said about the outpatient world, where you need a 27-hour day to do what you need to do. The inpatient world's no different. And sometimes I'm not proud of this. I wish it wasn't this way, but sometimes it's very easy to label people as, hypochondriacs, or they're drug seeking, or they're whatever it is, when the reality is they have like such great knowledge of their own problems of healthcare. But the reality is it happens. And those are the tools available to the ombudsman and ethics. Those are tools available to you at most places. But I would say just go to the place that knows you, because once you've had that epiphany, once you've broken through with a very, very difficult patient, you're like, oh, yes, I get it. I know, like, that is such a valuable thing that it's so difficult to get somebody else to do that. So you want to keep going back to the place that has that relationship with you. Because I'll just being honest, like it happens, and there aren't a lot of great choices of what you do to you'll have to be a strong advocate for yourself, and you'll probably come off as being difficult, but that's okay. You do what you got to do.
Yeah.
So.
And again, we're all vying. Again, these are triage environments. You're vying for attention, and
That's right.
there's probably a real skill set to the diplomacy that's most effective to navigating. Because sometimes, as a patient or a family member, it's motioning trust. Letting the doctor do their thing and not stopping them every 2 seconds. And sometimes it is stopping them. And boy, the diplomacy it takes to navigate this well is, again, another thing that's not taught anywhere. But this is where you draw on your sort of human skills of navigating people. And if there's something that's just not getting done, you can respectfully run it up the chain. So if the nurse or the doc at the bedside just aren't listening, you can say, hey, can I talk to the nurse manager on the floor? That might be a good next move.
Yep.
Then up the flagpole to ombudsman, et cetera. But Deb, yeah, to your friend and to you never just want to watch something dangerous happen. So don't be afraid to say, hey, I really need you to hear this. It can get a little awkward, but that's sometimes what it takes. I wish we had an easier answer for you, Deb. This stuff ain't easy. Okay, but let me I got to pop us out of this screen here to see where the hands are raised. So while I'm doing this, I want to pose a question, Deven, that our friend Mary, another long-term meddler, wrote in about. I think Mary, was it your niece? But the situation was essentially a relative who found herself in an ICU in an induced coma for some amount of time. And then coming out of the coma, had experienced a lot of paranoia and what might be called delusions. And it was very difficult. And apparently the symptoms lasted for more than a few days, even after the person had gone home from the ICU. So the question for Mary is really, what do we think about this ICU delirium and ICU psychosis even? What do we know about what an ICU does to our way of thinking?
So we know that those are very common things that happen now, things that we didn't really pay attention to before. ICU delirium, ICU psychosis are very, very common things. the thing to do for that is get out of the ICU or don't go into the ICU. But if you can't do that, we have some strategies where, the problem is the things that get you back to a life that you enjoyed, that made life worth living. It has nothing to do with any of that stuff you see in the ICU. It is not the machines, it is not the drugs, it is not the nurses, it is not the doctors. Those are all things that are designed to keep you alive. They do not necessarily get you back to a life. And being alive and having a life are two very, very different things. With enough machines and enough drugs, I can keep anybody alive. But getting you back to a life is actually the things, it's nothing to do with any of this complex stuff. It is the stuff that your mother told you was important. You got to eat, you got to sleep, and you got to exercise. And if you don't do those three things, nothing else we really do matters all that much, in my opinion. Okay, so first, eating in the ICU. You're intubated, you're on the ventilator, you're sedated, you're not awake, you're dying. You can't sit there and eat a good solid meal like you would at home. Now you have artificial nutrition going through a tube into your stomach or your bowel, but that's the best we have to offer in the year 2022. But that is not the same as having a good solid meal at home. Sleep is another one. Like we know, withholding sleep from people, I'm pretty sure is a form of torture that is used in some certain situations, right? When you come into the ICU and you see your family member lying there unconscious, they are unconscious, but that does not mean they are sleeping. So if you took a normal, healthy person and you didn't sleep for 2 weeks, just imagine what your brain would be like. Now, if you take a sick person in the ICU, they haven't slept for 2 weeks either. You didn't know that because they're unconscious, but they haven't slept for 2 weeks or 3 weeks or a month or however long it's been in the ICU. What we know is being unconscious on those drugs helps us with the life support that you're on, but is not the same as sleeping at home in your bed. This is not the same as eating a meal at home. And the last is exercise, right? If you take any one of us, anybody on this talk today, if you just laid in bed for a week and did nothing, or 2 weeks or 3 weeks or a month, imagine the muscle mass that you would lose. And muscle mass is something that you need. You don't need to live this second. You need a heart to live now. You need a brain to live now. You need lungs to live now, but you don't really need muscle to live right now. But over 3 weeks or a month, if you lose muscle mass, you can't get back to a life. So the difference between being alive and having a life, you need muscle mass to get back to a life. So you can take a shower and make your meals and walk to your neighbors or whatever it is you do, right? So those are the things that you lose the longer you're in the ICU. So developing psychosis is not very surprising when you put in that context. When you look at your family member, you have to understand that their unconsciousness is not the same as sleeping at home in their bed. There is no quick answer to anything. There is no quick answer to nutrition. Imagine if there was, we would all be amazingly healthy. There is no quick answer to strength and mobility. Imagine what this world would be like if we could just instantly take a pill or be on a machine and get a bunch of muscle mass. But there is no quick answer to any of those things. So the psychosis, the delirium should go away. There is a separate phenomenon of ICU post-traumatic stress disorder, PTSD, which we know happens now. Again, you could just imagine being sedated, not really being conscious, not knowing, but there's a machine that's pushing a breath into your lungs, whether you want it or not, right? Imagine how disruptive that would be. So you're not awake enough to know what's going on, but you're not completely unresponsive in that you don't feel it. So you've just been living in this world where something's poking you, something's prodding you, something's breathing into you. So these things are happening to you, but you don't know why, you don't know how, you don't know any of those things. It's not surprising when you think about it in that context that psychosis, delirium, and PTSD would develop.
So right on. So and to be clear, Deven, the patient can experience psychosis and the patient can experience PTSD, and both are more common than we realize.
That's right.
So these are very real, and it's not a matter of willpower. If you find yourself confused in an ICU, it's actually very common. We interrupted your sleep cycles, etc. But to be clear, the PTSD you mentioned is not just for the patient, it is often also for the family members. We know that grief and trauma post-death in an ICU is different from at home, for example. So for our job here, I think it's important for us to at least name these phenomena. We don't have time, or I don't know that we even know how to sort of fix these phenomena, but knowing about them allows for communication around them, allows for more clarity around them, and ultimately allows for more action. So for delirium in an ICU, there are medications that can be helpful for that.
That's
So
right.
sometimes there are things to do, but sometimes all we can do is be aware of it. And at least then we don't have to kind of second guess ourselves or whatever else is going on.
Yeah, I think to go along with that as well, a common question we get a lot of when people are in the ICU and family aren't sure, should we continue to be aggressive? Is this consistent with their previous goals of care? Things like that. What they'll usually focus on is pain. They'll say, is he having any pain? I want to make sure he doesn't have any pain, doesn't have any pain. And what I often remind them of is, I can kind of control pain pretty well in the ICU. I mean, I've got a lot of drugs that can do it, but there is all kinds of suffering that is not pain.
Mhm.
And these are the kinds of things: delirium, psychosis, PTSD, all of these things develop. There's no pain drug for something like that. The great example I would say is getting the cold or flu. And now most people are familiar with COVID, right? When you have COVID or you have the flu, there's not that much pain. I mean, there is pain, but it's not like horribly unbearable pain. But there's a lot of suffering, right? There's all kinds of suffering that don't have to do with pain. So you could imagine that as your lungs fail, as your kidneys fail, as your livers fail, as your heart fails, there's all kinds of suffering that has nothing to do with pain at all. So keeping that in mind when making these decisions, I think is important.
Yeah, the suffering is a complex beast, emotional, spiritual components to it, all sorts of very sensitive. It's complicated. Okay, man, wow, we've just opened lots of cans of worms and it's over now. And guys, I'm so sorry for the audience too. We missed Sonia. I can't even figure out how to see who raised a hand. So I'm sure we didn't get to a lot of things. We'll do this again, guys. My apologies for the technical errors on my part. But I hope this was as fun for a conversation for folks in the audience, or an important conversation for folks in the audience as it was for us. Deven, I could talk to you for a long time. There's just so much here. So anyway, hopefully we can do it again. And thank you for taking time with us, buddy.
Sure. Happy to come back too if there's more questions or anything. So
perfect. Yeah, let's do that, please.
Okay.
And my best to the audience. Happy weekend, everybody.
Very good. Thanks, everybody.
Thank you.
Thanks, bye.